In a prostate cancer patient, treatment with a long-acting gonadotropin-releasing hormone agonist was associated with the development of nocturnal pain in the region of the bone metastasis and a rise in PSA levels. To alleviate the symptoms, the patient's initial therapy was supplemented with flutamide, which resulted in a marked reduction in pain and shrinkage of the primary tumor. What is the most likely explanation for flutamide's impact on the patient's condition? Now, this patient is presenting with prostate cancer. Remember that prostate cancer is going to be a testosterone dependent cancer. What this means is that cancer cells in the prostate, just like other cells in the prostate, need testosterone in order for it to grow and proliferate. So imagine that this is a cancer cell in the prostate. So I'm going to write P for prostate. And these cells are going to have testosterone receptors on their surface. And when testosterone binds to the receptor on their surface, it is going to allow for these cells to grow and proliferate. Now remember that testosterone is going to be primarily produced by the testes. So I'm going to write TEST for testes. Let's just spell the whole thing out. So this is going to be the testes, and the testes are going to be producing testosterone, and that testosterone is going to bind to the receptor on the surface of the cancer cells, and it is going to allow for these cancer cells to grow and proliferate. So for the treatment of prostate cancer, we want to ultimately decrease levels of testosterone because testosterone is what is allowing these cancer cells to grow. So in order to do that, we can surgically remove the testes, or we can give patients medications like GnRH analogs, which are ultimately going to work by decreasing levels of testosterone. So this is what this patient was initially given, but his symptoms worsened because he had elevated levels of PSA. He had a rise in PSA levels as well as an increase in the growth of his tumor. Now, the reason why this is happening with this patient is because GnRH analogs like goserelin and leuprolide are going to given patients continuously in order to tire out the anterior pituitary so we get a reduction in LH and FSH. But when we first give patients GnRH analogs, it is going to cause a startup flare because GnRH normally is going to stimulate the anterior pituitary to produce LH and FSH. So before tiring out the anterior pituitary, we can actually have a rise in LH and FSH, and this is bad because LH is going to stimulate the Leydig cells in the testes to produce testosterone. And remember that testosterone is what causes the cancer cells in the prostate to grow and proliferate. So imagine that this is a cancer cell in the prostate and testosterone is going to bind to the receptor to allow it to grow and proliferate. So when we give patients GnRH analogs initially, it is going to cause a startup flare, which is going to increase levels of LH and FSH, which is going to increase levels of testosterone, and then testosterone can worsen the symptoms. Now, over time, with GnRH analog use, when we give patients a continuous dose of GnRH analogs, it is going to tire out the anterior pituitary, which is going to then decrease levels of LH and FSH, and now we're going to get a reduction in testosterone levels. In order to prevent this startup flare that the patient had experienced, we can give patients testosterone receptor inhibitors. So if there is an initial rise in testosterone levels, because we have a testosterone receptor inhibitor, it is not going to cause this startup flare. And so that is why the patient was given flutamide, which is going to be a testosterone receptor inhibitor. And so it is going to work by impairing androgen receptor interaction. And then this is going to allow for the startup flare not to happen. So it is going to prevent the startup flare from happening as it inhibits the testosterone receptor in the prostate.